Chapter 36, Loss and Grief. Loss is an inevitable part of life. Accompanying each loss are feelings of grief and sadness. Whether a patient is facing infertility or an amputation, an unwanted diagnosis, or an impending death, the nurse can offer both the patient and family support to cope with loss and comfort when continued life is not possible. Life changes are normal, expected, and with age, people learn that change always involves a necessary loss. Maturational loss is a form of necessary loss that includes all normally expected changes across the lifespan. The toddler experiences separation anxiety from a parent when starting preschool, for example. Some losses may seem unnecessary and not part of an expected maturational process. These can be sudden, unpredictable external events that bring about a situational loss. An actual loss occurs when a person can no longer feel, hear, see, or know another person or an object. Perceived loss is uniquely defined by the individual experiencing the loss and may be less obvious to other individuals. This patient appears to have accepted that they're going to die soon. What support would you offer to this patient? As we go through this chapter, consider grief and loss as they pertain to this patient's husband and daughter. Grief is a normal, but yet difficult to understand cluster of ordinary human emotions that arise in response to a significant loss. They are intensified and complicated by the relationship to the person or the object that is lost. Grief experience is a process. It cannot be prevented, and it is very personal. No two individuals will grieve the same loss the same way, nor do either individual journey through grief in the same fashion. Grief work is very hard and requires an enormous amount of energy from the griever. It is rarely orderly and predictable. Mourning is considered the outward social expression of grief and the behavior that is associated with loss. Most mourning rituals are culturally influenced and learned behaviors. Bereavement encompasses both grief and mourning and includes the emotional responses and outward behaviors of a person experiencing loss. The nurse should allow individuals experiencing bereavement to talk about their loss and reassure them that their feelings are normal. Normal grief is also known as uncomplicated grief. This is a common and universal reaction that is characterized by complex emotional, cognitive, social, physical, behavioral, and spiritual responses to loss and death. Some normal feelings of grief are disbelief, yearning, anger, and depression. Anticipatory grief happens before the actual loss or death will occur, especially in situations of a prolonged or a predicted loss, thinking about an individual that has a terminal illness. Family members often grieve the impending death of a loved one because of the impending loss of companionship, control, and a sense of freedom, as well as the mental and physical changes experienced by their loved one. Disenfranchised grief occurs when the relationship to the deceased person is not socially sanctioned. They cannot be shared openly, or it seems of a lesser significance. The person's loss and grief do not meet the norms of grief acknowledged by their culture, thereby cutting the grieving person off from social support and the sympathy provided to individuals with more socially acceptable losses. With complicated grief, a person has a prolonged or significantly difficult time moving forward after a loss. These individuals may experience a chronic and disruptive yearning for the deceased. They may have trouble accepting the death and trusting others. They may feel bitter, emotionally numb, or anxious about their future. Complicated grief has prolonged symptoms of painful emotions and sorrow for more than 1 year. You are caring for a patient who is very depressed because the only child has gone away to college. The nurse will assess this type of depression as actual loss, perceived loss, situational loss, or maturational loss. The answer is D. When life keeps moving, like kids growing up and moving away, it is considered a maturational loss. The stages of dying according to Kubler-Ross. Number 1 is denial. This is where the individual cannot accept the fact of the loss. It is considered a form of psychological protection from a loss that the person cannot yet bear. Number 2 is anger. The person expresses resistance or intense anger at God, other people, or the situation. Number 3 is bargaining. The person cushions and postpones the awareness of the loss by trying to prevent it from happening. Number 4 is depression. The person realizes the full impact of the loss. Number 5 is the acceptance. This is where the individual will incorporate the loss into their life. Criticism does exist for these stages and task theories because they fail to capture both the complexity and the diversity of the loss experience. No individual's grief follows a predetermined path, nor is it linear. Grief is cyclical with movements forward and backward. There are different strategies for dealing with questions for which medical professionals have no answer. The nurse should ask open-ended questions to explore the family's concerns. It is important to listen carefully and validate the family's feelings. The nurse should honor the patient and family preferences, the culture and religious traditions during this meaningful event in the family's history. There are extensive nursing education programs that do support the improvement of the end-of-life care for individuals. The patient's age and stage of development will affect the grief process. When loss involves another individual, the quality and the meaning of the lost relationship will influence the grief response. The losses that patients face from the time they were children will often influence the coping skills they will use when they are faced with larger and more painful losses in their adulthood. During times of loss and grief, both patients and families will draw on both the spiritual and social practices of their cultures to find comfort, expression, and meaning in their experience. Hope is a multidimensional concept that is considered to be a component of spirituality. It can energize and provide comfort to individuals and families that experience personal challenges. Hope gives an individual the ability to see life as enduring or having meaning or purpose. With hope, a patient can move from feelings of weakness and vulnerability to living life as fully as possible. The dying person's Bill of Rights. I have the right to be treated as a living human until I die. I have the right to maintain a sense of hopefulness, however changing its focus may be. I have the right to be cared for by those who can maintain a sense of hopefulness, however changing this may be. I have the right to express my feelings and emotions about my approaching death in my own way. I have the right to participate in decisions concerning my care. I have the right to expect continuing medical and nursing attention, even though cure goals must be changed to comfort goals. I have the right not to die alone. I have the right to be free from pain. I have the right to have my questions answered honestly. I have the right to retain my individuality and not be judged for my decisions that may be contrary to the beliefs of others. I have the right to expect that the sanctity of my human body will be respected after death. I have the right to be cared for by caring, sensitive, knowledgeable people who will attempt to understand my needs and be able to gain some satisfaction in helping me face my own death. The symptoms of normal grief. For feelings, there will be sorrow, fear, and anger, guilt, anxiety, loneliness, fatigue, hopelessness, yearning, and relief. An example would be a dying patient who cries often, has angry outbursts, and reports nightmares, gives evidence of several possible nursing diagnoses: pain, acute or chronic, dysfunctional grief, or spiritual distress. The nurse will examine the available data, validate the assumptions with the patient, and look for other validating behaviors and symptoms before making a diagnosis. Nurses provide patient-centered, holistic care to patients that are experiencing grief, death, or loss. A care plan for a patient who is dying focuses on comfort, preserving dignity and quality of life, and providing the family members with emotional, social, and spiritual support. What concerns do you have about the end-of-life pain management? Health promotion in complicated grief, serious chronic illness, or death focuses on facilitating successful coping and optimizing physical, emotional, and spiritual health. Many people continue to look for and find meaning even in difficult life circumstances. The primary goal of palliative care is to help patients and families achieve the best possible quality of life. The World Health Organization summarizes palliative care philosophy according to these words: provides pain relief, affirms life and regards dying as a normal process, intends neither to hasten nor postpone death, integrates the psychological and spiritual aspects of patient care, offers a support system to help patients live as actively as possible until death, offers a support system to help the family cope during the patient's illness and in their own bereavement, uses a team approach to address the needs of patients and their families, including bereavement counseling, will enhance the quality of life and may also influence the course of illness. This is applicable early in the course of illness, along with other therapies that are intended to prolong life, like chemo or radiation therapy. Hospice care is a philosophy and a model for the care of patients and their families at the end of life. It gives priority to managing a patient's pain and their other symptoms. It provides comfort, quality of life, and attention to physical, psychological, social, and spiritual needs and resources. Patients accepted into a hospice program routinely have less than 6 months to live. The heart of nursing care is the establishment of a caring and trusting relationship with the patient. The patient-focused approach allows the nurse to respond to patients rather than react, and it encourages the sharing of important information. Managing the multiple symptoms commonly experienced when patients are chronically ill or dying remains a primary goal of palliative care in nursing. The spiritual concept of hope takes on special significance near the end of life. Nursing strategies that promote hope are quite often simple, by being present and providing whole person care. Many patients with terminal illness fear dying alone. Patients with chronic disease often become socially isolated by choice. In palliative and hospice care, patients and family members constitute the unit of care. When a patient becomes debilitated or approaches the end of life, family members also suffer. They describe caregiving at the end of life as unpredictable, frightening, and anguishing. There are specific physical changes near the hours or days before death. There will be increased periods of sleeping and unresponsiveness. There will be circulatory changes with coolness and color changes in the extremities, nose, and fingers. The nurse will note cyanosis, pallor, and mottling. There will be bowel and bladder incontinence, decreased urine output. The urine will become dark colored. There will be restlessness, confusion, or disorientation. A decreased intake of food or fluids due to their inability to swallow. There will be a congestion and increased pulmonary secretions with often noisy respirations. There will be an altered breathing pattern known as Cheyne-Stokes. These are a pattern of apnea and labored or irregular breathing. There will be decreased muscle tone, relaxed jaw muscles, sagging mouth. There will be weakness and fatigue. For documentation of the end-of-life care, it will include the time and date of death and all the actions taken to respond to the impending death. There will be a verification of death according to the healthcare agency policy, the name of the healthcare provider that certifies the death, the people who are notified, healthcare providers, family members, organ request team, morgue, funeral home, spiritual care providers, and the person who declared the time of death. the name of the person making the request for the organ or tissue donation, any special preparations of the body, any medical tubes, devices, or lines are left in or on the body. Personal articles are left on and secured to the body. Personal items are given to the family with description, date, time, and to whom they were given. The location of body identification tags. The time of body transfer and destination, and any other relevant information or family requests that help clarify the special circumstances. Talking with the patient's family, involving them in the caretaking process, and educating them about what to expect from the experience will improve the quality of life of the patient and the family. Nursing interventions involve reinforcing patients' successful coping mechanisms. During evaluation, the nurse should be alert for any signs and symptoms of grief. As a first-year nursing student, you are assigned to care for a dying patient. To best prepare you for this assignment, you will want to complete a course on death and dying, control your emotions about death and dying, compare this experience to the death of a family member, develop a personal understanding of your own feelings about grief and death. The answer is D. The nurse cannot provide patient-centered nursing if the nurse does not understand their own feelings about death and dying. Every part of the evaluation process achieves a goal. Asking about changes will let the nurse know if the family are skillful in recognizing subtle symptoms in the patient's status and are proactive about controlling the symptoms. Observing the family after 1 week provides an understanding of the family's increased knowledge and ability to perform palliative care. Family sharing will help to develop and strengthen relationships within the family.